Yeah, thank you. It's indeed great being here, seeing all safe and healthy back, and in our mission to move things forward for our patients, for improvement in myeloma care. And yeah, we focused yesterday on the anti-BCMA antibody-drug conjugates in a symposium, and my part was a bit taking together that those antibody-drug conjugates really now adding with the anti-BCMA strategy a fourth pillar in the myeloma treatment, so extending our armamentarium consisting now mainly on immunomodulating agents, proteasome inhibitors, and the anti-CD38 antibodies. And we have two approved anti-BCMA agents. The belantamab mafodotin is an antibody-drug conjugate, and now most recently the first CAR T-cell treatment in myeloma, the idacaptid genviclucel, the ide-cel. And looking on the antibody-drug conjugates, we know that they have a kind of a payload with this, which is in the belantamab mafodotin, then the mafodotin, and which is then brought to the myeloma cell. And this leads to apoptosis, which is an immuno-independent mechanism, but those antibody-drug conjugates have also an immune-dependent mechanism. And we now know today that this is an antibody-dependent cytotoxicity and phagocytosis, but also an immunogenic cell death those ADCs can induce. And this is a very important mechanism because we saw in the pivotal belantamab mafodotin trials that patients who had to pause due to toxicity or other reasons, they could maintain their response. And now we know that this is mainly mediated by the immunogenic cell death and the immune-dependent mechanisms of those agents, that patients can remain their response. And so a very important message also for our patients and the treating physicians, that those agents have a very complex mode of action and act via several mechanisms. And this was kind of my part yesterday to elucidate this.